Hello, this is for the case discussion of the cerebellum. So, before we discuss the case, let us first discuss the anatomy and the functional functions of the parts of the cerebellum. So, the cerebellum can be divided either vertically or horizontally. So, vertically, we have the vermis, the midline vermis, which controls the trunk, and the hemisphere, which controls the ipsilateral upper extremity or lower extremity. If you have a lesion in the vermis, it would manifest into a truncal ataxia, whereas if it's the hemisphere, it's the ipsilateral limb ataxia. To divide the cerebellum horizontally, we have the horizontal fissure, dividing it anteriorly or and posteriorly. The primary fissure divides the cerebellum to an anterior and posterior lobe, whereas the posterior fissure divides the flocculus and the posterior lobe. The anterior lobe is also known as your spinocerebellum. The posterior lobe is your cerebrocerebellum, and the flocculus is your vestibulocerebellum. The anterior lobe, it functions for regulation of muscle tone, coordination, and coordination of skilled voluntary movement. For the posterior lobe, it functions as an influencer to the planning of voluntary activity, whereas the flocculus is for the maintenance of balance and control of eye movements. Therefore, if you have a lesion in the anterior lobe because it regulates the muscle tone, you would have hypotonia. And for the lesion at the posterior lobe, it would manifest with your tremors. For the flocculus, since it's for the eye movements, you will have nystagmus, and there's the maintenance of balance, so you will have the ataxia. So this is the case. We have a 67-year-old male. He is diabetic and suddenly develops dizziness. So it's sudden. So upon ER consult, the BP was recorded as 140/80, so that's high. He was awake but preferred to keep his eyes closed. If the patient is awake and not comatose, so there would be the preservation of the function of your activating reticular system. So that's located in the brainstem. So if that is preserved, we can say that some function of the brainstem is also preserved as well. So there is no gross cranial nerve deficit observed. The gross cranial nerves, it would the cranial nerves, they are housed in your brainstem. So if there are no lesions at the cranial nerves, we can say that the brainstem is also preserved. So he was able to move all his extremities against gravity. So there's preservation here of the strength of the patient. But he had difficulty doing finger to nose test and heel to shin test on the right only. So right extremities. He also had difficulty doing rapid alternating pronator supinator test on the right hand. So we can already localize the lesion. So, diba important yan to localize and the lesion for neurologic cases. So we can say that the lesion is located at the right cerebellar hemisphere. So, one hemisphere only. Kasi, localize yung symptoms mo only on the right side. And it would manifest mostly pagka cerebellum yung affected sa'yo, it's ipsilateral. So, these are our guide questions. So, for the first one, where is the lesion located? Is it the right or the left side? And we have to explain our answer. So, again, it's on the right side because of the double decussation of the efferent cerebellar pathways. If we are talking about efferent cerebellar pathways, yung important dyan is the superior cerebellar peduncle. Your middle and inferior, so they could have some efferent, but they are mostly afferent. So yung efferent mo, it would be the one that would cause the symptoms such as yung dysmetria and dysdiadochokinesia. So this is the schematic diagram of the globose emboliform rubral pathway, which has an effect on your ipsilateral motor activity. So let's trace it. The globose and from the right, globose and emboliform nuclei of the cerebellum, the efferent outputs would go to the superior cerebellar peduncle. From the superior cerebellar peduncle, it would cross the contralaterally towards the red nucleus of the midbrain. Then, when it already reaches the red nucleus, the efferent outputs would go to the contralateral motor neurons in the spinal cord. So, bumalik lang siya. So, yung motor neurons mo would be the ones that would innervate yung muscles mo. So, if yung lesion mo, if it's above the superior cerebellar peduncle, so if the lesion is here, or the nuclei itself, ipsilateral yung manifestations mo, as seen in the case. However, if it's after the superior cerebellar peduncle, so if the lesion is here, yan, hindi na siya makaka-cross. Therefore, ang manifestation mo naman would be contralateral. So, yung superior cerebellar peduncle mo and the red nucleus would be the one that would dictate whether if it's contralateral or ipsilateral. So, ito lang yung summary. So, where is the lesion located? It's at the right. Lesions that occur before the superior cerebellar peduncle would manifest with ipsilaterally, and if it's after the superior cerebellar peduncle, most notably if the lesions are in the brainstem, it would be the contralateral hemiataxia that would result. So, what positive neurologic findings did you see in the case that help you localize? So, the examiner asked the patient to do the finger to nose test and the heel to shin test, and only at the right side yung nagkaka-difficulty si patient. So, these tests actually test for dysmetria, whereas your alternating pronator supinator test, so right hand lang din, so again, it's only the right hemisphere that is affected. So, your rapid alternating pronator supinator test, it is for your dysdiadochokinesia. If the patient additionally has third cranial nerve deficits on the left, where will you put the lesion? So, let us disregard the case for a while. So, yung case kanina, sinabi niya na yung hemisphere yung affected. So, wag muna natin isipin yan. Isipin muna natin yung this one. What if nagkaroon ng third cranial nerve deficits na? So, nakalista here yung mga syndromes that would manifest with such, which is the ipsilateral third cranial nerve palsy and contralateral hemiparesis and extrapyramidal signs. So, pagka ganito yung binigay sa'yo, ang susundin mo lagi para malaman mo if it's the left or the right that is affected would be the cranial nerve. So, why is that? So, here, kasi yung cranial nerve mo, ipsilateral, hindi naman siya nagde-decussate. So, yung right cranial nerve mo, it would control din yung right eyes mo. Tapos, paano naman if malalaman natin yung saan yung signs and symptoms ng cerebellum and corticospinal tract? So, we have to note na binigay sa atin is cranial nerve 3. So, nasan ba siya? Nasa midbrain siya. So, pagka cranial nerve 3 or even 4, yung cerebellar signs and symptoms mo would be contralateral. Kasi, isang decussation pa lang yung nangyayari. Pagka idadagdag lang natin dito yung corticospinal tract, the manifestation naman would be contralateral kasi the decussation of your CST is at the lower 1/3 of the medulla. Paano naman kung yung cranial nerve that is affected is yung 5, 6, or 7 mo? Saan naman yung cerebellar signs and symptoms mo? So again, Para malaman mo if it's the right or the left side that is affected, susundin mo yung cranial nerve. So, yung cranial nerve mo, if left side yung affected, left side din yung lesion. So, left pons siya. Yung cerebellum mo naman, dito na siya mag-iiba. So, magiging left side na yung signs and symptoms mo kasi at the level of the pons, na-complete mo na yung double decussation. So, nakabalik na siya. And again, it's after the superior cerebellar peduncle. Diba yung SCP yung ating landmark kanina? So, if it's after that, ano na siya? Ipsilateral signs and symptoms na. So, left na rin siya. For the corticospinal tract, so it's contralateral pa rin. So, same rationale because of the decussation at the lower one-third of the medulla. So, ito lang siya. Kung paano natin siya dissect, so, alam natin na third cranial nerve. So, if it's either third or fourth cranial nerve, it's located at the midbrain. Therefore, yung cerebellar signs and symptoms mo would be contralateral. So, with the clinical presentation of the patient, what will be your complete diagnosis, including the possible etiology? So, it's acute infarct on the cerebellar right hemisphere. It's acute kasi it was sudden. Acute infarct siya kasi infarctions occur more predominantly than that of hemorrhages. Tsaka yung hemorrhage signs and symptoms wala dun sa patient. And again, it's only the right hemisphere kasi right signs and symptoms lang yung minamanifest ng patient. At saka na-discuss naman natin yung double decussation niya. So, if you have any questions, you can message me. And I would want to thank my friends who double-checked the table as well as who gave me the diagnosis. I would also like to thank my group mates for this case.